Welcome. My name is Dr. Jaih Craddock, and I'm an assistant professor at the University of Maryland School of Social Work. Today, I'm going to present my study titled Differences in Sexual Health Communication, the Use of Latent Class Analysis to Inform HIV Intervention Tailoring for Young Black Women. So just a little background. So cisgender Black American women account for 57% of all new HIV infections among US women. And this is due to challenges in identifying which Black women are at elevated risk for HIV, due mostly to complex, multifaceted factors associated with HIV acquisition. And these factors can be dynamics in sexual networks or access to resources and welcoming HIV testing locations, or lack in knowledge and prevention awareness. So why am I focused on sexual health communication within social networks of young Black women? Well, research has indicated that it is that sexual health communication is associated with HIV prevention behaviors among youth and young adults. And currently, most of the research focused on sexual health communication among young Black women aged 18 and older has focused mostly on sexual health communication with sexual partners, and with little research really focusing on the communication with peers and family members or other social network members. But we really know, we know that sexual health communication and sexual health knowledge doesn't only come from sexual partners, but it may also come from friends, family, church members, classmates, roommates, and other individuals they may interact with in their lives. So understanding who young Black women are speaking with and how those differences in who they're communicating with are associated with HIV prevention behaviors is really important. So why did we decide to use latent class analysis to look at sexual health communication among young Black women? Well, latent class analysis is a method that is used to provide insight into patterns of behaviors, and in this case, sexual communication, to identify subgroups within a population, and in this study, young Black women. And in this study, we're really trying to identify subgroups of young Black women based on who they speak to about condom use, STI testing, and HIV testing. And then from there, we really want to understand how do these different underlying profiles of young Black women, how are these profiles associated with HIV prevention behaviors, such as actual condom use, HIV testing, interest in PrEP, and previous participation in HIV prevention interventions. So typically in research, we look at young Black women as a whole, and then we work with these young Black women and provide them with interventions. We're really not looking at the differences and how these differences may be interacting with behaviors. So what did we do in this study? So this study was conducted in June 2018 to December 2018. We started off, we used responder-driven sampling, which means that as we recruited young Black women, we asked them to recruit 3 other eligible young Black women to participate in the study. We started off with 14 seeds of young Black women, which means initial participants. And these initial participants were recruited from various community organizations in Los Angeles, on Twitter and on Facebook. To be eligible for the study, young Black women had to be 18 to 24 years old of age, identify as Black African-American women, and ever be sexually active. And particularly in this analysis that we're talking about today, we focused on anal and vaginal sex only. So what does responder-driven sampling look like? This is what it looked like. We have 14 seeds. We had 427 total referrals. Some were online, some were in person. And then we end up having 159 completed online and 42 completed in person, because as this is a piece of a larger study that did both mixed methods, so qualitative and quantitative data collection. And so that's where the in-person recruitment comes from. So in this analysis, we had a sample of 180 young Black women. The mean age was 21 years old. Even though we started recruiting in Los Angeles, because it's a social network study and it was respondent driven, people referred other young Black women that were outside of the California or Western region area. And so these are regions based on the CDC region. So 42%, most of our sample came from the South, 42% of our sample, followed by the West, which was 41% of our sample. 9% came from the Northeast, and about 8% came from the Midwest. In regards to education, most of the young Black women had some college, followed by a bachelor's degree. Our outcome variables was ever been tested for HIV, reported using condoms at last sex, and reported being interested in using PrEP for HIV prevention. And about 72% had ever been tested for HIV, 40% reported using condoms during last sex, and 36% reported being interested in PrEP for PrEP use for HIV prevention. These are the descriptive statistics for sexual health communication. When it came to condom use, you can see that's the type of communication most of these young Black women had, mostly with friends, followed by sexual partners. And then testing was a little bit less, STI testing. Again, followed friends, they spoke to the most, followed by sexual partners and then family. And then for HIV testing, they actually spoke to sexual partners more than friends, but friends more than family. And that was the least form of communication, talking about HIV testing among these young Black women. So what did we find? So we found 7 classes of young Black women based on who they speak with about sexual health. So class 1 really focused on young Black women who spoke to family members and friends about condom use only. So they really didn't talk about STI testing or HIV testing, and they didn't talk to their partners really about sexual health either. Class 2 spoke to friends and partners. So as you can see here, class 2 spoke to their friends about condom use, STI testing, and HIV testing, and also spoke to their sexual partners about condom use, STI testing, and HIV testing. Class 3 focused on, or these young Black women spoke to family members and friends about sexual health topics, so condom use, HIV testing, and STI testing. Class 4 spoke to everyone in their network, or every one of their friends, family, and social sexual partners about all 3 topics. Class 5 only spoke to friends about condom use, STI testing, and HIV testing. Class 6 only spoke to partners about condom use, STI testing, and HIV testing. And class 7 really didn't speak to anyone about any of those topics. So right here, you can already see there are some differences between these groups of this group of young Black women. There's 7 classes and they're speaking to different people about different topics in their networks. So what else did we find? So how is this related to HIV prevention behaviors, right? So class 1 condom use, they were significantly less likely to ever be tested for STI. They're talking to their friends and family about condom use, and they're less likely to ever be tested compared to class 4. And I forgot to mention that this is a univariable multinomial regression model with class 4 as the reference group. So compared to class 4, they're less likely to ever been tested for HIV. They were also less likely to participate in the HIV program. Class 2 didn't really have any differences between class 4, and that's the one who spoke to friends and partners. So they didn't speak to family, but they did speak to friends and partners, and their sexual behaviors were very similar to were not significantly different than class 4. For class 3, they were less likely to have sex in the prior 30 days. And this may be because they're not talking to, this may be related to why they're not talking to sexual partners, meaning that because they haven't had sex in the prior days, they're not really discussing these topics with their sexual partners. Class 5, friends only, they were less likely to have sex in the prior 30 days, just like class 3. But when they did have sex, they were more likely to use condoms compared to class 4, and they were less likely to ever be tested compared to class 4. So you can see something here where they're more likely to use condoms, but less likely to get tested. So when we're thinking about developing interventions for this group, we may need to focus more on encouraging them to use, get tested for HIV, but not really focusing on condom use. Class 6 didn't really have any differences, sexual partners only when compared to class 4. And then class 7, there was a marginal significance in not ever participating in an HIV prevention program. This highlights that this class is not speaking to anyone about sexual health topics. And so there might be a need for this class, even though it's a marginal significance. It's there that they may need to participate or be engaged in some kind of HIV prevention program to help them increase their communication about sexual health with their social network members. And here you can see, even though this is not significant as well, but they are about the same odds of having sex within the prior 30 days as class 4, but they're less likely to communicate with they're not communicating with anyone, and they're less likely to have participated in the HIV prevention program. So what does this all mean? So really, without assessing subgroup differences, a highly effective intervention may not be as effective for similarly homogeneous populations, meaning that there's differences between these young Black women, and we need to tailor these interventions or even personalize the selection of interventions for young Black women. So knowing that these young Black women have different needs and different ways of communicating about sexual health and who they're communicating with, they may need specific kind of tailoring of interventions geared towards them. Everybody may not benefit from the same intervention. So being able to use data to say, okay, based on who you're speaking with and your sexual behaviors, let's select a more personalized option for you to, intervention for you to participate in. So there are some limitations to this study. This is a cross-sectional study, so it was just one point in time. Data were self-reported from young Black women, and the study was respondent-driven, meaning that young Black women were also connected to the other young Black women in the study. They were referred by their friends. So acknowledgments, I would like to thank the members of the Community Advisory Board for their time, support, and guidance on this project, and the young Black women who participated in this study. The research could not have happened without you, and I appreciate and I'm grateful for all of your participation. 200 young Black women participated in this study, and I really value their views and their participation. Also, I want to thank my funding agencies. So my F31, which was funded by the National Institute of Minority Health and Health Disparities. Currently, my KL2 is funded by the University of Maryland Institute for Clinical and Translational Research. And then also my fellowship, which is funded by the HIV Intervention Science Training Program at Columbia University. And then I couldn't have done any of this without my mentors and the support of my mentors at USC in the School of Social Work, Eric Rice and Julie Cedarbaum, as well as Dr. Norita Milburn, and then also the support of my mentors at the University of Maryland School of Social Work. Thank you so much for listening and attending my presentation. If you have any questions about the data or this project or future directions, please feel free to reach out. I would love to speak with you. Thank you for your time.